good afternoon, good morning, good evening, depending on where you are in the world tuning into this really interesting session. My name is Margaret Hellard. I'm a Deputy Director at the Burnet Institute and been involved in hepatitis C and hepatitis B research and elimination efforts for a number of years. I'm delighted to introduce my co-chair today, Theobald Owusu-Ansah from the Hepatitis Foundation of Ghana, and is a sort of an Afro board member related to the World Hepatitis Alliance. And we're really thrilled to be to chair this session on innovations in technology and service delivery. Before I start, though, I would like to acknowledge, as we do in Australia, the traditional owners of the land on which I'm chairing this session from today. I'm on the land of the Gadimal people, back at the Otway Ranges in Australia, and I'd like to acknowledge elders past, present, and anybody who may be on the line from First Nations, and I would like to sort of commend the ongoing custodianship of the land, which the Aboriginal people in Australia have done for thousands and thousands of years. Okay, our first speaker today is a person that I know very well from work we have collaborated on. It's Dr. Soniel Shilton from FIND. She's the Deputy Director of Operations and Implementation Research. Soniel, over to you.
Great. Ooh. Thank you. The challenges of navigating Zoom, hybrid, in-person. So thank you very much, Margaret, and thank you for the invitation to speak with everyone today. I will share my slides. So I'm here to speak about hepatitis C self-testing and just provide a very quick overview of this, and then two colleagues will present more in-depth, exciting details of the preliminary results of first ever real-world impact studies on hepatitis C self-testing. So to give a little bit of background about self-testing for hepatitis C. Now, when we're talking about self-testing for hepatitis C in this context, we are meaning the antibody test. It's also important to note that self-testing is not here to replace other testing modalities. It is rather a supplementary or an additional option. And it's not a definitive test, but rather the first step towards learning a status. And currently, it is research use only. There are no hepatitis C self-tests that are currently available on the market that have stringent regulatory authority approval. So WHO issued the first ever recommendation on hepatitis C self-testing in July last year. And the recommendation is that hepatitis C self-testing should be offered as an additional approach. It's a strong recommendation based on moderate quality evidence. And a lot of that evidence actually came from leveraging the existing evidence we have on HIV self-testing, with a few key points being supplemented specifically for hepatitis C self-testing. Additionally, there is a really nice video about community perspectives and community voices on hepatitis C self-testing that you can find in the link here. So some of the evidence that went into this WHO recommendation that was specific on hepatitis C self-testing was some feasibility and acceptability studies. We did these in a variety of countries using both the oral fluid and the blood-based test. And there was two ways that we looked at the feasibility and acceptability. In one case, we provided an in-person demonstration. So these were participants who were attending to clinic for other reasons, and then they were enrolled in the study. They were provided an in-person demonstration of the hepatitis C self-test, and then we asked them to perform the test, and the study staff sat by with a checklist, a standardized checklist, to understand how they could complete each of the steps. What we see here is that the majority of participants interpreted the results correctly and had a high agreement with the professional use test. So what we can see is that the in-person demonstration ensures high usability in populations, even in those who have a lower educational background, such as we saw across these three countries. The second way that we looked at this was in an unassisted model. So in this case, And participants were recruited, again, attending to clinic for other reasons, and the participant was given the instruction for use and then asked to perform the test. There was the study staff that observed the participant with a standardized checklist. And what we see here is that there is still high interpreting results correctly and agreement with professional use tests. However, there was more difficulty in completing all of the testing steps without making errors. So what we can say is that unassisted testing did lead to more frequent mistakes. However, these mistakes did not have a major effect on test results. I would also like to highlight that particularly among the people who inject drugs group in Vietnam, they had an 88% interpreted the results correctly. So this indicates, and Dr. Ketevan-Svele will talk more about this, that some of the additional supportive measures we may need to consider when using hepatitis C self-tests among people who inject drugs. So we also looked at values and preferences, and we looked at a variety of populations for this. So general population, healthcare workers, men who have sex with men, and people who use and inject drugs. And the main messages that came out of the values and preferences were, first, that more information on awareness and knowledge on hepatitis C in general must be done, that there is a limited amount of knowledge and there's a real need for continued education. The second strong message was that non-discriminatory services for people living with hepatitis is key, particularly among those who may be marginalized for other reasons, such as people who use or inject drugs or men who have sex with men. And then the need for context-specific rollout strategies with the supportive materials, such as illustrated instructions for use and supportive videos and other materials. We also did some cost effectiveness analysis in partnership with the University of Bristol, and that work showed that hepatitis C self-testing has the potential to increase the number of people diagnosed, however, at a slightly higher cost, and the incremental cost seems to be driven a lot by prevalence. And we'll be continuing to work with the University of Bristol to do the cost effectiveness analysis on these real world studies that my colleagues will speak of now. So we've done 3 studies so far in Georgia, in Malaysia, and in Pakistan, looking at different models of real world uptake and linkage for hepatitis C self-testing. And today we'll hear from Georgia and Pakistan. So turn it over to them. Thank you very much.
Thanks so much, Sonia. That's just super interesting and super important work. So thank you for the work that Fine's been doing in leading this. It's now my pleasure to introduce Dr. Ketevan-Svele. Ketevan is the manager of the Global Fund HIV program in Georgia and has been a real force de majeure in pushing forward the extraordinary elimination program in Georgia. So over to you, Ketevan.
Thank you very much, Margaret. Sonia, it's my pleasure to present today hepatitis C self-testing impact study that we are implementing in Georgia among 2 key populations, people who inject drugs and MSM. Study is implemented at 2 geographic locations, capital city Tbilisi and Black coastal city Batumi. And we are using existing self-test G platform. Platform was established for HIV self-testing within the Global Fund HIV program for testing of key populations during COVID-19 epidemic, and we integrated our study into this platform. We have very interesting study design. Overall number of participants that we plan to enroll is 1,250, 750 in intervention group and 500 in control group. We have 5 arms, 3 intervention arms that are different in terms of modes of distribution of self-test, and 2 control arms. In control arms, people who are enrolled in the study, they just follow standard steps of care. In arm 1 for MSM, participants receive self-test through courier service, Global Mobile Delivery Company. In arm 2, MSM receive tests from peers, and same is for people who inject drugs. They receive tests from their peer supporters. After completing self-test, participants read results and then they go to online platform to register results and complete baseline and 2 follow-up surveys. And we incentivize them for completing follow-up surveys in the form of small credits on their telephone accounts. When we looked at the preliminary results of people who are enrolled in the study, we found that 36% of participants were never tested for hepatitis C before, and 23% said that they did not know if they were tested. And the larger number of those who reported that they were not tested were among people who inject drugs, and also those who said that they did not know if they were tested. We also wanted to know if they had experience with any kind of self-testing before, and 41% said that they never used any self-test. And others reported using either HIV self-test or COVID self-test or both. As of the results, 87% reported negative results for testing, and 3% reported positive result. This is 13 individuals, 12 people who inject drugs, and 1 MSM, 7 in control group, and 6 in intervention group. In understanding of test results, 95% said that they well understood and read test results. 20 individuals reported that they had difficulties in reading test results, and as Sonil has mentioned, more people who inject drugs have difficulties in understanding test results. For example, in our case, 12 individuals in our intervention group for people who inject drugs could not read test results. As of the impact, this is very preliminary data, of course, but you can clearly see difference between intervention arms and control arms in terms of uptaking hepatitis C antibody testing. So in intervention groups for MSM, 86 and 94% completed self-test. In a control group, only 53%. Among people who inject drugs, 90% in intervention group completed self-test. In control group, much less people went to the community center or healthcare facility for testing. We wanted to know what would be the preferences in the future for testing for hepatitis C. And 62% said that they would like to do this kind of test at home independently. 7% said that they would do at home, but with assistance. And only 4% said that they would like to go to a healthcare facility. 21% would like to go to community center for testing. We also asked specifically on hepatitis C self-tests, what they will do if they will be provided with test kits and instructions how to do it. And 80% of overall number of participants said that they would like to do self-test. When we looked at the actual distribution of answer by study arms, MSM are more willing to do self-tests. For example, in intervention arms, 94%, control 89%. And among people who inject drugs, this percentage was lower, 72% for intervention and much lower for control group, 58%. We also asked about testing process and asked them to rate different steps or different attitudes or understanding of the test results. And they enjoyed very much security during the process. They well understood test results. They liked privacy during testing. They said that the testing process was very convenient. But to our kind of surprise, they found that testing process was not easy for them. More than 60% of participants said that the testing process was not easy, but it depends what we are comparing with. In community centers or healthcare facilities, whenever they go, everything is performed, of course, by lab workers or nurse. And in this case, of course, they had some difficulties in performing tests. Also, slightly more than 50% of participants said that this process was kind of stressful for them. What lessons we learned so far? As Sonil has mentioned, MSM are using self-test much better, and they are willing to do it in the future. People who inject drugs have some difficulties in reading self-test, but they are also part of people who inject drugs who are using these services. And from HIV self-testing, we already learned that there is a large segment of individuals who will be using self-test if they are provided with additional support in the form of video instructions and also follow up by peer workers or case managers, because, as you know, linkage to care is another challenge. Thank you very much. It was my last slide.
Thanks, Ketavan. Super interesting. It's now my pleasure to introduce Dr. Alia Hasnain from the Aga Khan University in Pakistan. Alia, over to you to present, please.
Thank you. Good afternoon. This is Alia Hasnain from Aga Khan University, Pakistan. I'm delighted to be here to speak about our experiences with hepatitis C self-testing. So Aga Khan University, in partnership with FIND, has carried out a study to assess the impact of hepatitis C self-testing in general population from a high HCV burden area in Karachi, Pakistan. The study is now in its concluding stages. We have finished recruitment, and now we are in the process of analyzing data on linkage and focusing on linkage to care. So Pakistan has one of the highest prevalence rates in the world, with an estimated national average of 6%. And within the country, there are recognized hotspots where the prevalence exceeds the national average of 6% by a far. So there is an ongoing microelimination study that targets a similar high disease burden area. And in that high burden area, there are selected union councils in the district Malir of Karachi, where the study aims to achieve highest possible elimination. So the self-test study is actually nested within this ongoing microelimination study, which is a community-based model where the study staff goes door to door, screening individuals for hepatitis C, and then linking them to care, providing treatment. And this is an entirely door-to-door based model. Okay, so the study aims to evaluate the acceptability and impact of a program that is enabling home delivery of hepatitis C in Malir District, Karachi Division. So like I mentioned, the study setting it's based in two union councils of District Malir of Karachi, namely Union Council 9 and Union Council 10. So Union Council 9 is the more rural population, and Union Council 10 is a more peri-urban population. So a first round of screening has been completed in these two union councils. The neighborhoods in Union Council 9 and 10 have been grouped into clusters, and the clusters have been matched in terms of similarity of geography, which is peri-urban versus rural population size, age, and demographics. So each member of a matched cluster has been paired and then randomized into intervention group and a control group. So approximately there have been about 1,200 participants from each union councils who have not previously been screened, for the simple reason that they were not found at home when the study team was conducting the first pass round of hepatitis C screening. Like I mentioned, each union council has been divided into 10 blocks, and then the clusters within these union councils have been matched. So the study staff visits these houses where there is an identified household member who has not previously been screened. If the household member is found to be home during this visit, then the blood-based rapid test is done on site. If they're not found to be home, then depending on what group they fall into, if it's the intervention group, a hepatitis C self-test is left with instructions for use explained to a senior household member. And in the control group, a pamphlet is left with directions to visit a nearby facility to have the blood-based rapid test performed. And the target sample size was a total of 2,000, with 1,000 falling in each arm. Both these groups are then followed up by the study staff within 4 weeks to inquire if testing was completed, and then the results reported are incentivized, and individuals who have a positive test are then linked for further care. So a subsequent house visit is done for blood draw for RNA testing and evaluation of liver disease. So far, we have recruited 2,185 participants, which actually exceeds our target sample size. This was because during the first round of recruitment, the number that was recruited was actually lower than what was anticipated, because a lot of individuals did not fall in the eligibility criteria for the screening. Either they were not found to be at their houses, they had moved out, or they were found at home during that visit. They were screened using blood-based test instead of being recruited into the study. So for that reason, we actually had to extend our clusters and include 4 more clusters to meet our target sample size, because of which we ended up enrolling about 1,184 participants in the intervention arm and 1,001 participants in the control arm. So as you can see, there is a drastic uptake in the intervention group, which is the group that is left with the self-test kits. 87% of participants in the intervention arm reported completing the tests, which is 1,026 out of the 1,184 that were recruited. The mean age across both groups is 30 years, and the majority of participants, around 80% of these participants, are males, because that is, in this cohort, it's the males who are often not found at home because they're away for work. About 51% of the participants who completed self-testing had received no formal education, and 95% of the participants who reported completing testing demonstrated willingness to perform a hepatitis C self-test independently in the future. We are currently doing a more in-depth survey to understand the perceptions of self-testing on a small cohort of participants who have either completed or not completed testing. In the control arm, the testing was completed only by 22% of the individuals, because the challenges in this group were actually going to a facility and getting screened, which was not feasible for a lot of individuals recruited in this arm. So in order to extend the advantage of increased screening uptake to the population and increase and cover the control group participants who had not completed testing, we actually did a crossover study where we left self-test kits for participants in the control arm who had not completed testing by going to a nearby facility. So this is currently in process, where we are still handing out self-test kits to these participants. Preliminary results show that 777 of these, out of 777 participants, 665 have been encountered again to leave a self-test kit at their houses, and 66% of these participants who previously did not complete testing by visiting a nearby facility have now completed testing using a self-test, and the prevalence in this population is 11%. We are currently working on the care cascade by collecting blood samples for RNA testing and assessment of liver cirrhosis, and initiating treatment in this cohort. So the challenges in so far have been that this is a hard to reach population that are not found home during work hours, or sometimes not found to be home for a whole week because they go away for work. And while self-testing has drastically increased screening uptake in the intervention arm, the challenge remains in getting hold of these individuals for blood sample collection, for treatment initiation, and so on. But to conclude, results of the study demonstrate that hepatitis C self-testing does increase screening rates in a setting like this. It's a peri-urban and rural mixed setting, which consists mostly of illiterate population in a low middle income area. And like I mentioned, linkage to care remains a challenge in this hard to reach population.
Thanks very much, Leah. Really
Thank you.
interesting work going on, showing innovative ways forward with this. Our next speaker is Camilla Piquillo, actually it should be Piquillo, from who is a project manager and pre-doctoral fellow at the Barcelona Institute for Global Health. Over to you, Camilla. You're on mute, Camilla, just in case you haven't realised.
Sorry, I couldn't get out of the other screen. There we go. Now, can you see the screen and hear me?
Yes, you're not
Great.
in presentation view. If, now you are.
Wonderful. Okay, thank you so much. Apologies for the technical difficulty. I'd like to thank the organizers first for the opportunity to share our research. I'm actually going to be breaking up this presentation into two different studies, talking about the plasma separation card for the use of viral hepatitis screening among African populations. First, I'm going to be speaking about the study that we did in Kampala, Uganda on behalf of my co-authors. And afterwards, I'm going to be speaking about using the plasma separation card in a different model of care among West African migrants here in Barcelona. So just to get us started, hepatitis B is a public health challenge in Uganda where the prevalence varies across the country, but can be as high as 15% in the northern part of the region. Hepatitis C is currently not well studied in the country, and this is due in part from a lack of diagnostic capacity and lack of consistent resources like reagents and the lack of trained personnel. So the objective of our study was to evaluate the use of the plasma separation card for viral hepatitis screening in an urban HIV clinic in Kampala. So we were based at the Chirudu National Referral Hospital. And for those of you who are not familiar with the plasma separation card, it is something similar to a dried blood spot test. However, through a porous membrane that the card has, it allows only the plasma to go through, and that actually separates the plasma from the whole blood without needing centrifugation or to be kept in cold chain. So basically the final product, instead of being dried whole blood, is actually a dried plasma spot, which can then easily be transported to a lab to be analyzed. The technique is highly sensitive and specific for viral hepatitis biomarkers. So it's been tested for Hep B, Hep C, and anti-Delta antibodies as well. So last year, between May and July, those attending an HIV clinic in Kampala for regular care or for a first visit were offered hepatitis B and C screening. Their trained nurses collected 400 microliters of blood. Each little circle that you see there on the plasma separation cards require 120 microliters of blood, so in total 420. And the samples were left to dry for 4 hours and afterwards put in just in a regular bag with some desiccant in and transported to the Central Public Health Lab, which is of the Ministry of Health of Uganda. And afterwards, participants were asked about the acceptability of the testing method, the levels of pain, and the likelihood to recommend the testing method to friends and family. So this is a pilot study. So we reached 88 participants, but the data that I'm presenting here is still preliminary and it's only for 70, who were primarily female, about 40 years old, and of the Ganda ethnic group. And overall, the hepatitis B prevalence was about 13%, and no one had detectable DNA. Also worth noting that all these patients were HIV positive and had been on treatment for some years, and we did not find anyone with hepatitis C. And the mean sample collection time was about 10 minutes, which is great because most of the respondents, I can't see my own little screen. The majority of respondents believe that the sample collection, the whole process should take less than 15 minutes. Primarily, 65% of people reported the method as being not at all painful, and almost everyone would recommend the plasma separation card to friends and family. So overall, if given the opportunity, respondents would choose the plasma separation card over the gold standard, which in this case would just be regular phlebotomy for routine viral hepatitis testing. So if we just compare quickly the general sample with those who were positive, we see some differences in education level, whether someone already had a family member with hepatitis B and liver cancer, and also worth noting that the large proportion of people had heard of hepatitis B and C before. So in conclusion, it was found, the plasma separation card was found to be a very acceptable and feasible collection method. It's had a high acceptability and low levels of reported pain. And overall, participants were satisfied with the method and would recommend it to others. So this tool could be used to increase viral hepatitis testing across Uganda and also in other similar settings. So to switch gears a little bit, I'm going to also speak about HBV Comme Ça Va, which is our community-based screening program for West African migrants in Greater Barcelona area, where we also use the plasma separation card. Just to give a little bit of context, in Spain, 20% of the population are foreign-born individuals, of which about 30% come from intermediate and high endemic countries of hepatitis B. And in Catalonia, where Barcelona is located, the foreign-born population is about 16%, but also have a high proportion of people who have immigrated from intermediate or high endemic countries. So of course, recommended to implement target screening programs for these populations. So the objective of HBV Comme Ça Va is to use point of care diagnostics. So in this case, we use the rapid test for hepatitis B surface antigen and also the plasma separation card to collect blood samples out in the field for African migrants. We also link them to care and vaccinate if needed. So since November of 2020, we've gone on 42 visits and we're able to screen 444 people who were primarily male, about 40 years old as well, and predominantly from Ghana. 21% of these are recently arrived migrants, so they have arrived within the last 5 years to Spain. And our prevalence has been, for current infection, we found a prevalence of 9%. For past resolved infection, about 41. So in total, we have about half of the participants have current or past resolved infection of hepatitis B, and 48% had no prior immunity. In the sense, we did not look at anti-S, which I know is going to be a question later. So we're basing this off of just surface antigen and anti-core and their self-reported vaccination status. And our linkage to care so far overall has been 72%. So this is based off of, basically we do 2 visits, first where we do screening and the second where we provide the results and offer vaccination if needed. So overall we're able to link about 3 out of 4 of the participants, but of course there's still work to be done. But worth noting is that for those who were positive, we were able to link them to care, to specialist care. We were able to link 93% of those participants directly to specialist care. And that's it. Thank you very much.
Thanks very much, Camilla, for another really interesting couple of studies there. I suspect there'll be a few questions for you as well in that, so it's great. It's my pleasure now to introduce Associate Professor Sunil Solomon from the who's Professor of Epidemiology and Medicine at Johns Hopkins University in the United States. Over to you, Sunil.
Thank you, Margaret. I want to start by thanking the organizers for an opportunity to present here today. So I think my topic is going to be quick start of hepatitis C treatment, and I will try and be quick as possible. So I just want to start with a little background about why are we talking about quick start. And I think one thing we need to remember is medications directly acting antivirals for management of hepatitis C really have evolved over the past decade. And we no longer use interferons. We have pan-genotypic regimens. There's almost no need for on-treatment monitoring anymore. And they're all really associated with extremely high SVR, like 95, 97%. And so there's like really, and I think the most important thing is also the introduction of generic DAAs, which really have brought down the cost of regimens, especially in low and middle income countries, where access to diagnostics may still remain a challenge. The other thing we also have to remember is like every step we add from the time of like screening to the time we start them on treatment poses an additional barrier when people may drop off along the continuum. And this is something we've seen with every other infectious disease, especially HIV, where every step you take and you have them do like a CD4 or something else. And so we almost moved to like rapid ART initiation, same-day ART initiation. And so we need to start thinking about how quickly can we get people started on DAAs for hepatitis C. The other point I also want to mention is the cost of inaction. So sometimes we want to be perfect, we want to get all the tests done, but sometimes it's not available. And when we send people away, we end up losing a lot of these people who never come back. And so we're actually losing patients who need treatment because of our inability to get them on treatment right now. And I think there's also been a lot of evidence in recent years to suggest that simplification does not really compromise SVR. So I want to just go over a couple of key studies that talked about simplification of DAA delivery. And I want to focus more on the SMART-C and the MINMON trial, which I was led, which was a multi-country trial in low and middle-income countries as well as high-income countries. And SMART-C was only in high-income settings. So a couple of key things I want to point out is in MINMON, we had no requirement for a pre-treatment genotyping. In many low middle-income country settings, that ends up being a barrier. I think the WHO has taken it off because we do have pan-genotypic regimens now, and we only use the FIB4 to classify people as serotic or not serotic. The other thing I also want to point out is in both these studies, so SMART-C used GP, which is glecaprevir and pibrentasvir, and we used sofosbuvir, velpatasvir, and MINMON. We dispensed the entire course of medications at study entry. So there was no on-treatment follow-up for refills of medications. The one thing I want to point out across all those studies was that there really was no on-treatment clinical monitoring at all, and no on-treatment laboratory monitoring. Because we really have evolved to a point where we do have extremely efficacious regimens that are also extremely safe. The one thing I do want to point out is all these studies excluded serotics except for the MINMON trial, which included compensated serotics. And I think the other thing that we are getting more and more used to today is remote contacts and telemedicine visits. And so each of these studies have like a different frequency. But the one thing I do want to point out is despite like simplifying the way we were delivering therapy and the requirements to start treatment, almost all of them achieved SVR that was comparable to the standard of care, especially with intent to treat, because if you look at other cohort studies that have looked at pool data, SVR overall, if you account for losses and treatment discontinuations, ends up being about 92, 93%, which is consistent with what all these different trials saw. So it really is possible to simplify the steps needed to initiate treatment without compromising efficacy or safety with these new regimens available. So what the evidence tells us today is we can do HCV antibody testing, confirm active infection using an HCV RNA, do a quick clinical exam, do some basic laboratory tests, do a FIB4 if someone is compensated. If someone is serotic, then do a CTP to rule out decompensated cirrhosis, do an HBS surface antigen, which is available as a strip test, assess for DDIs, and based on that, you can start them on one of these two regimens. Right? So I think we really have simplified it quite a bit, but now what I want to go to is like a little bit more controversial on how much simpler can we make it from here, and can we actually simplify this even further? So I think we already heard about HCV rapid antigen home-based testing, which is happening. So I don't think HCV antibody testing is going to get that much simpler than that. And we also know there's increasing evidence that you could really deliver all the treatment at one point in time. But I want to focus more on these two steps in the middle, because this can take anywhere from like 3 to 4 hours or 24 hours, all the way to 2 weeks, depending on where you are in the world and what access you have to diagnostics. And for a lot of people, waiting that period of time, especially if you're a long distance trucker or you're a vulnerable population, like a person who injects drugs, who's traveled somewhere else for this test, that ends up being too long and we end up losing these people. So I want to pose some questions, which I'm happy to discuss later. So in terms of the pre-treatment lab, so again, the one thing I want to clarify right now is like, I'm not saying we don't need to do these steps. The only question I want to ask is, do we need to know all these steps before we actually start them on treatment? Or can we start them on treatment similar to what we're doing in HIV with same-day ART, and then either modify treatment or stop treatment based on when the results come back? For example, like the biggest thing we really need to know at treatment initiation in terms of liver disease stage is, are they decompensated cirrhotics or not? And from a clinical exam, you can pick up several signs of this. And even from like talking to the patient, are you throwing up blood or do you have ascites? You really can pick up signs of decompensated cirrhosis. So that is something that we could use. And if they're not decompensated cirrhosis, maybe we should be starting them on treatment while we're waiting for all the other labs to come. And it's very unlikely that we are going to modify treatment, even if these other labs come back, because it is really indicated in most of these populations. An HCV RNA confirmation. So I think we do have the GeneXpert, which gives you a point of care test, but the availability of GeneXpert is also varied depending on which setting you're in. So the other test that has been getting a lot of prominence is the core antigen test, which has been validated and correlates pretty well with the HCV RNA in both active infection and in SVR. But I think what really would be a game changer in terms of confirmation of active HCV infection, and this is something that we should be thinking about, and I think there are some tests, is could we have a rapid antigen test that actually gives you like a strip test similar to the HCV home self-test that I talked about, where you could just do the test yourself or at the provider, it would tell you within minutes, do you have active infection or not? And so these tests may be less sensitive, you may miss some infections, but just want to remind you that missing a few infections is okay when the alternative is missing all the infections because of the lack of availability. And it's also something we have gotten used to with COVID, because we do rapid antigen testing almost all the time, knowing that it is less sensitive than a PCR. So it is something I want to throw out there. And then the last thing I want to end with is like, do we even need the HCV RNA confirmation prior to treatment initiation? In certain populations, like people who inject drugs, or even what they showed here, was in Pakistan, one of the groups was almost 86% were chronically infected. So could you just do a clinical exam to rule out prior treatment clearance, provide them with a 2-week starter pack, and then have them come back if they need to stop treatment or get the remainder of the treatment to them when those labs come back, if no modifications are required. And the one thing I want to also end with is like in some of these vulnerable populations, like people who inject drugs, this may actually end up being PrEP. And so it's very common in like liver transplants, especially organ transplants, where the recipients of donors who have Hep C infection actually take this as like pre-exposure prophylaxis to prevent acquisition of hepatitis C. So I just want to end with, so we've always been thinking about these 2 steps, but could we actually make it simpler and then just do a clinical exam, do a surface antigen to rule out hepatitis B infection, assess DDIs, and really start treatment and wait for the other tests to come and modify treatment as required. So I will end with that. Thank you. And I'm happy to take questions in the end.
Thanks very much, Sunil. Well, we can say, if I wanted to, great minds or strange minds think alike. We're doing a study in Australia called Quick Start, where one of the arms is literally just going, if you test antibody positive, do exactly that, take the bloods, but start the person with a starter pack. And we're doing a kind of a randomized trial looking at those things. Just again, I'm trying to get rid of it. And also, I think I'll be interested in your thoughts. I'll ask later about the kind of work that Jordan Feld's done, where the 5-minute antibody test, if it's positive within 5 minutes, the likelihood. So there's lots of different ways to begin to think about it, but really interesting and provocative. So thank you. Our final speaker today is Professor Peter Vickerman. Peter's a professor of infectious diseases modelling at University of Bristol. Over to you, Peter.
Okay, so I think I've got a recorded presentation because I was told I should do that. So although nobody seems to have done it.
Today I will be presenting a work we've done looking at the effectiveness of low dead space syringes for reducing the risk of hepatitis C acquisition amongst people who inject drugs. This work has been done in collaboration with the UK Health Security Agency. People who inject drugs use 2 types of syringes. Syringes either with detachable or attached needles, as shown in the figure on the right. Syringes with attached needles have less dead space, as shown in the red shading in the figure, and are termed as low dead space syringes or fixed low dead space syringes. It is thought that these syringes carry less blood after injection, so are likely to be less infectious if shared. The World Health Organization recommends the use of low dead space syringes to reduce the risk of HIV and hepatitis C acquisition. This is supported by lab experiments and also HIV and hepatitis C prevalence studies, which have shown that people who use low dead space syringes have a lower prevalence of HIV and hepatitis C. However, there is no current evidence that the use of low dead space syringes is associated with reduced risk of HIV or hepatitis C incidence. In this analysis, we test the hypothesis whether using low dead space syringes reduces your risk of hepatitis C acquisition. For this analysis, we used the Unlinked Anonymous Monitoring Survey from England, Wales and Northern Ireland. This is an annual biobehavioural survey of people who inject drugs recruited from services. The survey includes a short questionnaire about drug use behaviours and demographics, and for the 2016, 18 and 19 survey, it asked about whether they obtained syringes with attached needles. A dry blood spot is also taken from every participant and is tested for hepatitis C antibodies. From 2016, if an individual was antibody negative for hepatitis C, then they were also tested for hepatitis C RNA to determine whether they had recent primary infection. For this analysis, we include participants from the 2016, 18 and 19 survey that test hepatitis C antibody negative. For the statistical analysis, we defined a binary variable that defines whether somebody always uses syringes with fixed needles, which is defined as 100% fixed LDSS, or whether they use any syringes with detachable needles. We undertook logistic regression to estimate whether there's an association between always using fixed low dead space syringes and recent hepatitis C infection, defined as being RNA positive and antibody negative. Within the logistic regression, we adjusted for demographics, recent injecting risks, intervention access, and structural factors. Multiple imputation was used to account for missing data in the covariates. Within the 3 surveys, we had 4,473 people inject drugs. 2,981 of these were excluded because they were hepatitis C antibody positive, and a further 27 were excluded because they'd recently received no syringes. This meant that for our analysis, we had 1,465 people inject drugs. Of these, 63.8% of them reported always using fixed low dead space syringes. And when we looked at these individuals, we found that they had reported less chance of being ever incarcerated, less of them had ever were currently on opioid substitution therapy, and fewer injected in the groin. In the whole sample, we identified 33 recent infections, i.e. those that are RNA positive and antibody negative. Within those that always use fixed low dead space syringes, we found a lower prevalence of recent infection of 1.3% compared to 3.8% in those that used any detachable syringes. In the univariable logistic regression, we found that there was the lower odds of recent infection if you always used fixed low dead space syringes of 0.32. We also found that being of female sex or injecting crack increased your odds of recent infection, with no other variables being associated. In the multivariable logistic regression analysis, we found that always using fixed low dead space syringes was still associated with a reduced risk of recent infection with an adjusted odds ratio of 0.24, with injecting crack still associated with increased risk with an odds of 3.09. There was limitations to analysis in that we always used observational data, so it could be unmeasured confounding. So we also used a marker of recent infection, so there could be misclassification, with the gold standard for identifying new infections being longitudinal follow-up. We also only had 33 incident infections, so we had relatively low power. We also relied on self-reported data for all other variables, so there may be biases in reported or misreporting. And we used a simple variable of using syringes with fixed or detachable needles. Because of this, we could not assess the use of new detachable low dead space syringes, and there was an issue with some participants not completing all questions to produce the low dead space variable. In conclusion, even though there were weaknesses in analysis, we feel the results of our study are potentially important because they suggest that low dead space syringes with attached needles may reduce the risk of hepatitis C acquisition by 75% compared to syringes with detachable needles. This means that low dead space syringes could be an important prevention technology for eliminating hepatitis C. And as shown in a recent analysis by our team, it could be a cost-saving intervention because of the small cost difference between syringes. However, it's important to emphasise that further studies are needed to confirm our findings in other instance studies to assess whether there's a similar efficacy of low dead space syringes for HIV and to assess the efficacy of different syringe options, including low dead space detachable syringes. Thank you for your attention.
Thanks so much, Peter. I'm going to now hand over to my co-chair, Theobald, to run the Q&A session. So over to you, Theobald.
Thank you, Margaret. I have learned a lot this afternoon from the presenters, and they have done a good job. And my first question will go to, my first question will go to Kate. Kate, I want to find out, how do you ensure that those people who do self-testing at home are linked to care?
Okay. In our study, we have individuals registered by personal ID number. And using this ID number, we follow individuals in hepatitis C elimination database, which is a national database. Whoever will approach a system, healthcare system for RNA testing or enrollment in care, they're registered in the system, and by cross-matching our study database with a Hep C elimination database, we are constructing a Hep C care cascade for our study.
Okay, thank you. And second question also goes to Camilla. What are behavior change techniques can be adapted with LDSS?
I'm sorry, can you repeat the question?
I said, what behavior change techniques? What behavior change techniques can be adapted with LDSS?
With early access?
Yes.
With early access to testing?
Yeah, I'm talking about LDSS to testing, behavior change.
I'm so sorry, I don't understand the question.
Okay.
Perhaps, Camilla, I mean, I'd be interested in your view or others. Do you think, and I mean, they might have been talking about it with Peter with low dead space syringes, but I don't think so. But do you think that, say, people being diagnosed in an early way, you know, really early on might help in terms of how they might modify behavior or risk?
So being diagnosed early, knowing your status, how that's going to change?
Yeah, even if you can't get access to treatment. It's sometimes, say with hepatitis B, do you think there's a benefit even if you can't, maybe this is, I think what they might have been asking. In a situation where you may not actually be able to access treatment, but you've been diagnosed with hepatitis B or C early, do you think there's a benefit in terms of prevention or other things?
So I think both at the even without having, you're specifying it without being on treatment, right? So I guess that this would be at a public health approach, right? In terms of knowing if you know your status, but you're not able to be on treatment. So if you're not getting that individual benefit of being on treatment from a public health point of view, then there is benefits in terms of changing your behaviors to reduce transmission, onward transmission.
Okay, thank you. Camilla, sorry, I got the question wrong. Somebody sent a question to me through my WhatsApp platform. The question is, how is the plasma separation card designed?
How is the plasma separation card different from like a dry blood spot?
No, you want to find out how the card is designed. How do you design the card, plasma separation card?
I think how the card is designed would be the people who would be best able to answer that question is Roche Diagnostics, who are the ones who developed the card. However, just from my personal use, what I'm able to explain that it's about the size of a credit card. It's very thin. It's similar to a regular dried blood spot. So when you put however, has some filters and some membranes included, so that when the blood is spotted onto the circles, it's actually left in like a separate compartment that's easily able to be manipulated and transported.
It's just whoever just asked that, it's very similar to a standard lateral flow type of situation, and it can be done on, there's a number of different ones that are available that can do it. So it's just it's a very simple thing. It's just, it separates it in that sort of, that mechanism. So yeah, there's a few different ones available.
Okay, thank you. This question goes to Sonia. Somebody wants to know that you are doing excellent job, and any plans to extend your job to other African countries or more countries?
Thank you for that question. So currently, FIND is a catalytic organization, and so what we want to do is find other countries or geographic areas that are interested in expanding self-testing. Particularly, we are looking to partner with areas that already have treatment availability, because self-testing may be best suited to places which there's already clear pathway to RNA or viremia testing or treatment. But I guess we're always open to discuss with more collaborators.
Thank you. Let's go to the chat. I think people ask, let me read some of the message.
Well, I do have one kind of, I guess, question or comment, which is on, I think Sunil brought up an excellent point about the core antigen RDT. And just to say that, under the Unitaid funded Head Start project from that FIND was doing for a while, and that closed down last year, we did bring several prototypes through development of the core antigen rapid diagnostic test. And unfortunately, COVID has certainly changed diagnostic companies' priorities for a moment there. And so, we had found one prototype that was meeting our specifications, and we were in process of transferring it to a commercialization partner. So, it really depends on how that process continues, but we would hope to see some further movement. I mean, but just, I think it's important to manage expectations that it would not be as simple as a lateral flow for the antibody, right? Because getting the antigen out of the core as it is a bit of a technically tricky process. So there are some aspects around that. So while it still could be some type of lateral flow device, it probably would not be able to give you results in 5 to 15 minutes.
So Sonia, do you want to comment? Or anybody want to comment on sort of the kind of work that Jordan Feld and Jeff and others have been, Jeff Lazarus and others have been looking at with the antibody test with, if it's positive in 5 minutes, then the likelihood of you being RNA positive is so extraordinarily high that you could start to treat. The work that I was doing in Myanmar, the vast majority of people, as you will know, recall, Sonia, were RNA positive, and I just wondered whether I should just treat everybody that came in the door and tested antibody positive, or we're about to start some work looking at the 5 minutes. But really interested in other people's views on that, and whether you can just, if that was the circumstance, just not go to an RNA test.
I'm going to pass that one to Sunil.
I would definitely say you need an RNA test, Margaret, but like I said, I think it depends on the population. There are certain populations where it doesn't justify doing an RNA test at all. So if you're looking at a population,
I'm thinking cost as well as time, Sunil. So if you're not a wealthy person,
no, I completely agree. But so even if you don't do it at the time of treatment, you need to do it at some point to release it, to ensure that they were cured or something, so you don't retreat the same person over and over and over again. Right, because I think that becomes the problem. So So you could do quite a bit, but I think what we should be looking at going forward is maybe pooled RNA testing, right? So you actually distribute the cost across 10 people, especially at the SVR levels. If we do skip the RNA at baseline, in terms of cost, I think it makes sense in certain populations, at least at this point in time, if they've never been treated before, especially if they're actively injecting, it makes sense to just skip the RNA completely. But at SVR, I would suggest we pool them and test them, so at least we make sure that we've cured them, so we don't end up with cases in between.
Okay.
Anybody else want to comment on that?
I would like to comment on that. So we have actually, we have several studies going on in the field in Pakistan, and we have noticed a higher active viremia in patients who have screened positive within the first 30 seconds. It is actually 10% higher than the average active viremia. So perhaps if we cannot skip RNA testing, we can start treatment before waiting for RNA results in this population. So we can start same-day treatment. Just a
Okay.
thought.
Margaret, there's a question from someone you want to Camilla. You want to know how is the plasma separation card compared with other WHO pre-qualified rapid diagnosis tests for HB and HCV?
So it currently only has approval for HIV viral load monitoring. We're using it off-label for research purposes. I think there's a paper where a lab has validated the efficacy, so the sensitivity and the specificity for different biomarkers, and they are very high and acceptable.
Oh, okay, thank you.
I've just noticed the time, Theobald. I don't know. It's been such an interesting discussion. I suddenly realised that we've actually reached time and we have to stop.
Somebody wanted to know, but the machine just logged me off from online.
I think the session is
The session has ended, and I would like to
say,
thank everybody. You have done a good presentation, and as I said, I have learned a lot from here, and from that, I'm going to build another partnership for most of the presenters. Thank you very much for your time.
Great to see you all, and enjoy the rest of the conference.
Thank you.
Thank you all. You were great. Have a good day. Bye-bye.
Goodbye.